Okay, today we don't have a whole lot to talk about, rather just the systolic and diastolic pressure. And when that happens is we're referring to the ventricles only, okay? So I would be led to believe that the first portion that you hear in a blood pressure, that would be for instance, the lub portion, and then the dub after that. That's how it's always been explained to myself. And when you look at that, that's just the sound of the valves that are opening and closing. And when we look at systolic pressure, okay, which is when the ventricles are contracting, I believe, then the diastolic pressure would be when the ventricles are relaxing. And we left off yesterday. I guess I don't even know where it is we left off. Okay. So what is one way the human body can raise the blood pressure in the systemic circuit? In other words, it's circulating all throughout the body. What is one way that the body can compensate for that? And pumping blood faster is not the answer. And we're making you think with that, okay? One of them is a hormonal action. The other one is a blood vessel action. So how can blood pressure be raised? That's got a specific name to it. What is that? Like big snakes are called what? Yes. Like boas, pythons, and anacondas are known as the constrictors because they wrap themselves around, and when they're constricting, it's getting smaller. So that would be one way that the human body can raise its blood pressure. So what might be the other way to raise blood pressure with a hormonal action? Has something to do with water. And you've got it twofold. The reason I say that, we've talked about it in here, and we've talked about it in biochemistry. Sodium, that's just a small portion of it, though. Mm-hmm. Kidneys, and we're getting closer. I didn't hear what you said. Are you asking us or telling us? Yeah, it's aldosterone. That's right. Because when you put all three of those pieces together, the hormone, as it's circulating through the blood, okay, has an effect on the sodium ions in the kidneys. So then if the kidneys are retaining the sodium, the water follows the sodium, and then that will, as I'm explaining this is, I said it the wrong way. That will raise blood pressure because it's pulling water out of the blood. Okay, so then when that happens, if there's less water in the blood, is that more thin or more thick? And if it's more thick, is it easier to pump, do you think? No, it would be harder to pump, so that's going to raise the pressure. Okay, so those would be two ways that I believe would be led to believe the human body can raise its blood pressure. Okay, now, just the opposite. Sometimes what we learn in conventional science, that has been practiced for years, might not be the best way to approach different types of treatments. What I mean by that is, for instance, hypothermia. In your estimation, what is hypothermia? It has something to do with body temperature. Okay, so I would be led to believe that, okay, your body's trying to keep itself warm, and it's dropping to, okay, 95, 94, 93. It's time to be concerned. 92, and I believe this is correct. If for some reason the body temperature gets down into the 80s, that can lead to heart failure because the heart's just not going to pump if it gets that cold, okay? So it used to be that conventional wisdom would say if someone is suffering from hypothermia, okay, what is the best thing that we thought, okay, now not we in here, but the medical profession thought what's the best way to treat that hypothermia, okay? There's a right way to do that, and then there's a wrong way to do that. And it has to deal with not just these, but also arteries as well. Because when your body is really, really cold, especially in the wintertime too, what are your blood vessels doing? Are they dilating or constricting? And they're constricting. Why would that be a way to try to keep the body warmer? Yes, it's going to raise the blood pressure like we just talked about, but what are the veins and arteries at the body's surface going to do? Get bigger or smaller? And they're going to get smaller, so they're going to, what's the right way to say this? They're going to, I wouldn't say move away from the body's surface, sink in the body's surface, or the concept is they're getting smaller, so you can't see them anymore because they're constricting so much. Because it's, again, a last-ditch effect to try to not let that heat dissipate out like it is when the body gets hot. So now, if conventional wisdom would say, like you said, warm them up, there's a right way to do that and a wrong way. And should you put someone that is that cold into a hot water bath, okay, then those same arteries and veins are going to go through the opposite process, which is opposite vasoconstriction, but vasal what instead? So then if that happens really quick, all of a sudden all those big arteries just open up just like that. What do you think might happen to an individual's blood pressure? Is it going to go further up or is it going to go down? Why are you right? Right, so we already have established that if constriction's taking place, pressure is going up. So if you dilate that quick, pressure is going to go down. And if you happen to have that take place in all the large arteries in your body, your blood pressure is just going to go through the floor, sinking, and possibly put someone in shock, okay? And if it's severe enough, unfortunately, they may succumb to that and not get out of shock. And if I'm correct, I think shock is just when the blood pressure drops so low that and you can't get the heart started again. That's what I mean by we learn from our past mistakes. So what might be a better way to, not with heating blankets, not with anything like, or hot water baths or anything like that. I believe the blood is diverted, and that was just a small segment in gifted hands. If you remember during that surgery, how did they stop the hearts? They diverted the blood and put cold blood inside, circulated cold blood, and that would stop the heart. If you are doing that on purpose, okay, there's a medical reason for that. Then, after the two babies were separated and all the suturing was done in the brains, then they said, okay, warming the heart. How did they do that? They started circulating what inside of them? Warm blood, and that's going to slowly raise that core body temperature, so then they could shock the heart to get it started again, okay? Or excuse me, to get a signal to get that to jumpstart. Okay, all right, so atrial blood pressure, okay? And it happens in a phase, of course, we call the cardiac cycle. And if this term is not on your paper, I highly suggest you write it down. It's called the sinoatrial node. That is the pacemaker of the heart, or SA node. Okay, so then just opposite the systolic pressure then is going to be when these are going to relax, and then that would be the diastolic pressure. Okay, does everyone have this that wants it then? Okay, 'cause we don't have a whole lot left to go over for today. So one of the things that I think is worth discussing is the idea of the sinoatrial node. That is the pacemaker of the heart. In other words, it's telling the heart when to contract. So who gets the big heart? We've got 3 spots. Okay? It's not that it's a bad one. It's just you want the stand too. Okay? Do you want this? There's a stand that goes with this, very much like that. Is this okay? All right. We're just talking about, and it's not, and it does come apart, as you can tell. But one of the things that we want to discuss with this, and I don't know if this is such an important aspect to discuss, but these on the heart are actually, see, this is really missing on there. And these are called auricles. So those are on top of the atria. So I don't know if that's something that you need to know in the future, because when we talk about atria, that's the chambers inside. But the auricles are these structures on the outside here. So again, this sinoatrial node, what do we say that it is? And can we live without the sinoatrial node? It's kind of a trick question. We can. How and why? Okay, so we can surgically implant a pacemaker. It just looked blurry. I don't know if it's because I'm walking back and forth. So if that tells when the cardiac cycle should initiate and start, is it possible that that could, I'm not saying fall out of line, but start contracting when it shouldn't? Of course, that's why we put an artificial one in. So why would it be beneficial for these chambers to fill up with the maximum amount of blood, then contract? Okay, then the atria. Okay, so they're filled with blood, then they contract. Then it goes down in the ventricles. They get filled up and then contract. Okay, so why would it be an advantage for them to be filled up first and then fire or contract? And it's going to affect its pressure most certainly. And to me, I think what makes the most sense is if you could take a tube of, for instance, toothpaste and fill that with water, okay, if that was possible. If you fill that tube up half full and then squeeze it, how efficient would that be to get that water out of there? Probably not very efficient. But if you can fill that tube up and then it's full and then squeeze it, okay, then you're going to be able to push more fluid out of there. And that's basically how the heart works then as well. Okay, so the reason that you have those diagrams, or not diagrams, models, sorry, okay, one of the things that you're going to want to try to associate that with is, yeah, it's easy to do. I've done that 15, 20 times already, and I haven't had those models. You're not going to break it unless you throw it under your car and run it over. Then you might break it. Okay? But with that, if you decide to open that up, you can see the chambers inside. But what we want you to visualize is, okay, you can do this the easy way, which I don't recommend that you do, or you can do this a little harder, okay? And what I mean by that is as you have that model in front of you, that you have the apex of the heart closer towards you. So what that means is the apex is the very bottom of the heart where it comes to a point. If you point that towards you, that would be a better way to learn these. And the reason I say that, you could take the easy way out and turn that around. Then you won't get left and right mixed up, would you? Okay? But if you keep the apex closer to yourself, then it's like looking at that mirror image on a piece of paper or up here on the board. Okay? So, with that, okay, what are your three? I'm sorry. Someone was holding that heart in front of them, saying, "That's a pretty large one, isn't it?" Compared to, I'd say it's probably a little more accurate to what the other two have. Okay, so then, which one should we go in difficulty order or just random order? And for those of you, if you're tuning in later, it's just going to be a little more difficult because you can't see it, and I can't put the students on camera. You can only just listen to what we're doing. So in your estimation, would that be a good place to stop with the video but continue with this? Because I don't think anyone's going to get out of it anymore, or else I can just hit pause. I can do that. So the first question was, where's the inferior vena cava? So you got to take into account, you have to have blood drain from the cranial cavity, okay, and neck area, and it also has to be able to come up from below, from the feet through the legs all the way up to the heart. So you're going to have a superior portion, which is up on top, and then underneath you would have the inferior vena cava. So there's actually two vena cavas, one up on top, one on the bottom. Okay, where is a blue artery? Yep. Okay, so what circuit is that? What portion of the cardiac or circulatory system is it? Where's that going? Systematic? Where is that blood going? Okay, where's it originating from? Let's put it that way. You can backtrack on the heart. Okay, so if it's on the right ventricle, it's exiting through, what's the name of that? Because you pointed, that is a blue artery, but what's it called? You're going to go, oh, I knew that. Okay, Well, look on the other side of the heart, okay? The left side of the heart is part of what? Okay, and that's why we're going through this. The right side of the heart has the pulmonary artery, and pulmonary means lungs. So that means that's going to the lungs. So it's going away from the heart, but it doesn't have a lot of what inside of it? Oxygen. Okay? So then you would look at how is it possible for that to be one vessel, but yet go to both lungs. You have to look really close on that heart. Now you can tilt it and turn it around and see what you would need to do. I'm sorry, I'm hitting pause and resume and pause and resume. So if we're sending blood out of the pulmonary artery and you have a left and a right, they're blue in color, okay? That's because they're oxygen depleted. Then as blood is coming back to the heart, okay, it's going to be going through pulmonary veins that are not blue. They're actually what? And they're red because they've just had oxygen and carbon dioxide exchange in the lungs. And then those pulmonary arteries are going to empty into which chamber? The left atrium, okay? So, and I think that this is probably difficult because typically when we look at a design or diagram of the heart, okay, we got this, and once you start throwing questions in there, we think, okay, I got to think about the blood content, the oxygen content, so it gets to be a little more difficult in that sense, okay? And that's why we practice that. Okay, so then the last thing we'll do, because I see we're up to 23 minutes, okay? Now maybe the most trickiest aspect. I mean, we haven't even hit that yet? I don't know. So, which one is the left common carotid? That's right. Nope. Yep. Nope. Yep. Okay. So then where or what is the brachiocephalic trunk then? Nope. Yep. Yep. So then that leaves one tributary off, and that vessel is called what? It's an artery. Are you asking us or telling us? Yes, that's the left subclavian. Okay. The point behind that is we got to remember when that brachiocephalic trunk is coming up, it's going to break off into two tributaries. You're going to have the right subclavian and the right common carotid. On the left side there, in the middle, you have the left common carotid and then the left subclavian. For some reason, that's just, I think it's because how it's placed in the thoracic cavity and the lobes of the lungs. Correct, because we did the right side already. Were you in here? Yes, you had done it. You got that little saying that helps you with that. Okay, so that's all I have. We'll catch up to you next time.